And we now have your own very Mumbaikar, Dr. Shantilal Shah, Manish Shantilal Shah.
He's gone.
So he is going to resolve for me the issue that what exactly is the maximum medical therapy, and when should I push and how much should I push a patient for undergoing surgery, because frankly speaking, these things vary a lot. When I was younger, I was not sure of my surgery. I would give them 10 things that, oh, there's 2% chance the vision may go, this, that, and the patient will run away. But then gradually what I saw was that many of these patients came back blind. So then you realize that you really do not have many options. But let us listen to what Manish has to say with his vast experience in surgery.
Thank you, Harsh, and good afternoon, everybody. And maximal medical therapy, we have gone to the other extreme. We started discussing whether to treat, not to treat, initiate to treat. Now, these are patients who are essentially requiring a lot of treatment. They are on multi-drug therapy, and it is, as Harsh pointed out, a point which is always confusing what we are supposed to do. This is not going ahead.
वो देखो यार जरा slide देखो. मनीष माइक ऊपर कर लो थोड़ा.
Yes. Okay. So yes, yeah. So basically we are going to give drugs to reduce pressure. And how much drugs and how many drops should we put? Maximal medical therapy, what I understand, is which patient can tolerate, comply and adhere. So it is different for each person. It is not going to be a fixed formula. If you are expecting me to give you a fixed formula of how many drugs to give, that's not going to happen. I will give you a formula in the end, but that is not going to be about how many drugs. Customization is the key. So does that mean you do what you please? You know, very often when we say customize means whatever I want, I can do. It's not exactly like that. We have to be objective, because here we are dealing with a disease which can cause blindness. It can cause blindness on treatment. It can cause blindness when you operate because of the complications. So it is not an easy tightrope to walk. But we have to be practical. So put yourself into the shoes of the patient and see how you can put drops. In my experience, even after putting so much fear of blindness, most of the patients, after they have understood what is glaucoma, live in fear that they will go blind one fine day. But still there is a limit to how many drops and how you can adhere to a complicated schedule. So in my opinion, 4 to 5 drops a day, maybe in 2 or 3 bottles, seems to be a practical upper limit. Of course, if you can get away with a single drop and a single bottle, that's fantastic. But that's not the subset of patients we are discussing here. Most commonly, we have patients who are on brinzolamide, brimonidine combination with a prostaglandin analog, which can be in a fixed drug combination with a timolol. So here you are having 4 drugs in 2 bottles, and the patient needs to put it around 3 times or 4 times a day drops. This is very practical. Many patients can adhere to this. And there are other combinations like the combination with the topical carbonic anhydrase inhibitors with timolol, brimonidine with timolol, along with prostaglandin analogs. And nowadays, before the patient is really taken up for surgery, we have the option of adding the new drug, which is the ROCK inhibitor. Fortunately, we can get a ROCK inhibitor put only once a day. And there is a place for the timolol pilocarpine combination, which is not available today in India, but I hope it will come back in select situations, especially in pseudofakes. So these drugs we combine and try to give a combination which works and the patient can tolerate. There is personal variability. Some patients in extreme situations where they are living, one eye is already lost, this is the only seeing eye, and they are living in fear of blindness because they have lost the first eye due to a complication of surgery. There are significant number of patients whom I have followed up for a long time, and they are ready to put these drops in the schedule that you are giving them for a long time. So what is the cornerstone of your approach to these patients who are putting many drops? The first thing you have to keep in mind is what I called TCA, and this has to be evaluated by the treating physician. The tolerance, how much of local and systemic side effects which are bearable or not bearable. You have to make out what is going on. So most of the patients will complain. Some things the patients don't complain, and you have to actively go out and look for. Compliance is putting the drops at the right time in the dose that you have prescribed. So they are putting it in the right way. And adherence is able to following your schedule for long number of years. So that make it a part of their life. So you have to evaluate the patient from all these three, which I call TCA for short. So each patient is evaluated. The tolerance part is you see the patient's complaints on the drugs, evaluate specially for the red eye and the dry eye status and the lid pigment. Again, I would like to stress, patients may not complain, but you have to look at it. Compliance is a general inquiry, and I would share one formula which I have. I generally ask the patients, are you putting drops? They say yes. And then I tell them, oh, you put the Xalatan twice a day, no? And you put this Timolol once a day, and confuse them. So then they come out with what they are doing. And that is a nice way of finding out whether they are following your schedule or they are actually confusing everything. So it's an art. And the adherence part, whether the patient is likely or able to continue your regime for a prolonged period, is again a subjective thing which you have to evaluate based on what you saw in the first TCA evaluation. So each patient is assigned an arbitrary grade in my clinic, whether the TCA is good, okay or poor. So if I see a patient who is having too many complaints, has a red eye, and when I ask him leading questions about the schedule of drops and he tells me, yeah, this one I put in the morning, oh sorry, this one I put in the morning, and he is not sure, that means if he is not sure, means he's definitely not putting the drops as you have asked him to put. This plays a very important role, and I grade them into good, okay or poor. I'll come to this again. Then of course you proceed with the routine evaluation of the patient based on your visual fields, optic disc, IOP, side effects, compliance, adherence and general health. And I think we have had some discussion on all that a little time before. The next important point I would like to evaluate is the visual function. So what is a patient who has a good visual function? The visual field defects are moderate. Mean deviation would be between 12 and 18. Obviously, you don't usually have patients with early visual field defects on maximal medical therapy. It is not very common, so I have not included that, but you can include. And no involvement of the fixation, and over time, more or less, it is stable. This I would classify as good status visual function. Moderate visual function, where the visual field score is moderate or severe, but 10-2 central fields do not involve the absolute fixation. The points which are defective are at least 4 degrees away, that is 2 points on the 10-2, and stable on progression. These I would classify as moderate visual field function. And the next and the last are the poor visual field status patients who have a severe visual field defects with mean deviations more than 18, 20 or more 25 with fixation involved, and any of which is showing progression. So even if the visual field function is moderate but shows progressions in 3 consecutive fields, it is graded as a poor visual field function patient. So this is a kind of patient you see sometimes. It is an advanced defect, and over time there is progression. As compared to this is a patient who over time is not showing much progression. Then you come to the next point, that is, what is the pressure levels? You are following the target pressure concept, where you have evaluated and decided that my patient would be likely to remain good or stable at a certain target pressure based on the intraocular pressure, visual field status, age and other risk factors. So then you are going to check the patients. So you classify again into good, okay and poor. The patients who are maintaining target pressures less than target for more than 75% of your visits. Now you are going to do many visits, you are going to check pressure at each visit, and you are going to see whether it is in your target range. The others are the okay, those where the target pressure is there only 75 or 60% and it's about target the other times. And those whose target pressures are not even near the target levels for 50% of visits are poor control or poor IOP control patients. So then you are going to evaluate the life expectancy of the patient. And this is one question which came to me personally many times. Always we discuss target pressure based on life expectancy, and how do we know the life expectancy of an ex-patient? So I have gone online and done some research, and there are online calculators based And the mutual funds seem to be ahead of us. They have given us a formula. So NM mutual fund, which doesn't exist in India, has got a very nice age expectancy formula where you put in all the details and you can get an age expectancy. So I just put it here because I think that there must be many people like me who don't know the answer to this question. How do we work out the age expectancy of a patient? But there is a scientific method to do that also. And specific cardiovascular history and history of malignancy in last 5 years is a very important marker about the life expectancy of the patient. So when you are thinking about what to do to the patient, you have to have a rough idea what to expect, how long he is going to live. And the last and most important is the patient education or patient involvement. Now here I have this to say that you have to discuss the options with the patient, and obviously a patient who has moderate to advanced glaucoma, you have discussed many things with the patient. And you are always going to discuss the success risk versus the complication or failure risk. But all of us, including me, we all have always make decisions on what we want. But what we want is very clear. Everybody wants fantastic vision for throughout their lifetime. That is not a discussion. The discussion has to be on what you want to compromise. Now this is very difficult, but this is the first statement I make to my patient. We all know what you want. You and I want the same thing. We want good vision to last your lifetime. But what is going to happen if our treatment is not successful is what we need to discuss. And second important thing is surgery versus medicine is not an option. We have to take it as it is medicine with or without surgery. So I never promise a patient that you are going to do the surgery to get away from medicine. Okay, we may be able to get away from some medicines which you can't tolerate, but it is surgery with medicine. So the decision you need to make is whether to continue on maximal medicine or go in for surgery plus or minus medicine again. Next, can we remove that overtime thing? So then you have to make a decision whether to motivate the patient for surgery or you have to continue. Also, you have to decide at what frequency you will continue to monitor the patient's visual fields and involve the patient more. So as coming back to the 3 points I said, the 3 points I would like to evaluate is visual function, target pressure, and TCA. And how the patient is doing on each one of these 3 points will guide me to the decision. So if all 3 are good, I would be happy to maintain the patient on maximal medical therapy. Any 2 are okay and 1 is good, then I would say observe closely. But any 2 are poor, you would definitely move this patient towards surgery, and you need to discuss this more and more with the patient and reach your satisfactory conclusion. So as I would like to say at the end is, I hope I have made it a little objective for you to decide what to give in maximal therapy and how to decide when to move this patient from maximal medical therapy towards surgery. And one last point is use SLT. I think somebody mentioned SLT, I don't know, one of the previous speakers, and SLT can be used along with medicine as a part of the medical treatment. So I have not included that here, but it is one treatment which doesn't have any side effects and very good tolerability. So you would definitely use that as one of the modalities. Thank you.
Thank you, Dr. Manish. I think that was wonderfully done, because it is never an easy answer. But the truth is, if in front of you the patient's fields are deteriorating, or in front of you you see that the patient is not using medications because of the allergies or whatever, it is imperative that you operate. And the myth, it is pretty much a myth of the wipeout. So please don't be scared of that. But even better, as a general practitioner, if you don't want to operate, that's fine. There are enough people around you, especially in institutions, who will take that thing. So it is indeed, even the patient will be extremely grateful if you do refer them. And there are people who don't, like I told you, then when I didn't want to do the surgery, I told them, oh, there's a 2% chance your entire vision will go. But if you actually put it in context, and so one of the patients asked me, sir, but if I don't do, what will happen? Then I said, there will be 100% loss. So once you put 2% with 100%, there is no confusion at all. If there's any confusion, it is in your ability and your bravado to do that thing. And if you feel that you are not good enough, then please refer, because these patients have to be saved. And if it is an angle closure glaucoma patients, the earlier you operate or you get them operated, the better it is. So